Let's jump into chapter 26, soft tissue injuries. This is going to be part 1 of 3. So part 1, chapter 26. When we think soft tissue injuries, you've got to be prepared for them to run a whole range of things from cuts and scrapes to amputations. They can be very serious and even life-threatening, regardless of how significant they are. Your goal is to not become distracted and get tunnel vision based on the injury's severity and to recognize the life threats that truly do exist, remembering that our ABCs are the most important. We have to remember that there are a number of ways that we can get soft tissue injuries: blunt trauma, penetrating trauma, barotrauma, which are the injuries as a result of sudden air pressure, which we see in blast injuries, and then burns can also create soft tissue injuries. In any injury, soft tissue trauma is very common. So we see bruising and swelling and hematomas and lacerations, small injuries, and recognizing that death is likely the result of the hemorrhage or the infection that comes from that soft tissue injury. Our goal, of course, is prevention. So, reaching out into the community to put in injury prevention strategies and injury prevention education. But of course, we're not going to be perfect at it, so we need to be prepared to treat it when it happens. When we talk soft tissue injuries, we are talking about the skin and recognizing that the job of the skin, or the integumentary system, is to keep the important things inside our body and to block the dangerous things on the outside of our body from coming in. We have the potential to have soft tissue injuries and breakdown of the soft tissue due to external forces, so penetrating trauma, blunt trauma, etc., and also due to internal infections. The skin is fairly tough, but does fall prone to injury and is still very susceptible to injury. And we have to know how to assess for those injuries and how to recognize the life threats and treat the injuries. Our goal is controlling bleeding, because when the skin is cut, vessels will be damaged as well. Our goal is to prevent further contamination and to decrease the risk of infection from an open wound. Our goal is to prevent further damage. So a wound may have already occurred. Our goal is to make sure it doesn't get worse. And then our goal is to choose and apply the appropriate dressings and bandages to the patient so that we protect that wound and keep it protected from the infection and other damage. Our skin does vary in thickness. The very young and the very old tend to see thinner skin. They have less body fat protecting it, and as a result, have a higher probability of more damage from lower force. We have areas of our skin that are thinner regardless of our age, and that's the eyelids, lips, ears, scalp, back, and soles of our feet. We know that thin skin is more easily damaged than thick skin, and thin skin that is damaged increases a risk of more significant issues. There are two principal layers of the skin: the epidermis, which is that external layer that you see, and the dermis, the inner layer. Each of these layers has a significant role, and is made of many things. So the epidermis has a couple of layers that provide some protection and increase the thickness, provide some extra padding. And the dermis has all of the extra stuff. So the hair follicles, the sweat glands, the sebaceous glands, and blood vessels. And it's the blood vessels that run through the dermis that feed the skin and provide nutrients and oxygen, because the skin is cells. So epidermis and dermis. This shows you a cross section of the skin. So you can see the epidermis is kind of flaky, has some layers. And then when you get down into the dermis, which is thicker, you have all of the important stuff. So, you've got your nerves and your sweat glands, the hair follicles, and the blood vessels that come through and feed the epidermis. The erector pillae muscle actually are what create goosebumps and what pull and stand the hairs on their end. So that just kind of gives you an idea. And then, of course, under the dermis, you have the subcutaneous tissue. So you've got the subcutaneous fat and then the muscle that the skin sits on. The skin covers all of the external surfaces of the body. And then the body openings, the mouth, the nose, the anus, they are all lined with mucous membranes that provide that barrier against bacteria. So where the skin is not, where there is an opening, the mucous membrane kind of serves the same purpose as the skin in terms of providing that extra layer of protection. This substance, mucous membranes continually lubricate, your mouth, your nose, they always have, your eyes, they always have more of a liquid lubricated surface to ensure the safety and prevent bacteria from opening or entering the body. So the function of the skin, the functions are numerous. So as I said, it keeps the bad things out, keeps the good things in. The bad things being bacteria and pathogens, the good things being your organs, bones, muscles, and fluid. So because of our skin, it actually helps us with hydration, helps us regulate our body temperature. So when we're hot, we sweat. When we're cold, it will trigger the shivering. And then it provides the messaging to our brain about our environment, the pressure, the temperature, is it hot or cold? All of those are coming from the nerves within the dermis layer of the skin. Of course, any break in that layer, any break in the skin, any drying up and cracking of the mucous membranes increases the likelihood that bacteria can enter the body. And when bacteria enters the body, we increase the chances of infection, we increase the possibility of fluid loss, and we increase the loss of temperature control, all because of bacteria and breaks in the skin. When the skin is not fully functioning, we see our patient experience many issues. We refer to 3 different types of soft tissue injuries in the book. So we will talk about closed injuries, we will talk about open injuries, and we will talk about burns. So closed injuries is when there is no break in the skin. So the skin is still in a continuous layer, no breaks, and the damage occurs underneath or to the mucous membrane. So the damage is in the dermis, or it's in the muscle, the bone, the organs underneath. But that skin is still intact. Open injuries occur when there is a break in the surface of the skin or the mucous membrane. There is bleeding, there is an opening in the skin. And then that damage will then go further potentially to the other layers. So yes, a paper cut may just hit the epidermis, but a gunshot wound is going to go through the epidermis, the dermis, the subcutaneous, potentially into the muscle and a bone or deeper. And this, of course, increases the risk of contamination, infection, etc. The third type is burns. Burns occur and damage our skin and soft tissue as a result of heat. So whether it's thermal heat or frictional heat, toxic chemicals, electricity, etc., burns create soft tissue damage. So our 3 types of soft tissue injuries: open, closed, and burns. You need to understand what happens with the soft tissue injury and the body's response in order to recognize why it's important you do what you do when treating the wounds. So again, when we have a soft tissue injury, especially an opened soft tissue injury, we expect to see bleeding. And our primary goal, along with, of course, airway and breathing, is maintaining control of that bleed and getting control of the bleed so that our patient doesn't bleed out. So what we need to keep in mind is that it's that important, and controlling bleeding is so important because when we are losing blood, we are not appropriately circulating oxygen or removing waste. And so by controlling the bleed, we increase the amount of oxygen that is being passed to the body's tissues. It also causes problems with homeostasis. So if I am bleeding but not controlled, and I am not removing the appropriate waste or delivering the appropriate amount of oxygen, obviously my body is going to lack things that it needs. Additionally, once we can start to control the bleed, the body's going to be able to get to the next stage of wound healing, which is inflammation or swelling. As that's happening, the cells are already moving into that damaged area, and we've talked about how the platelets move in so that the clot can begin to form. But we also get white blood cells moving into that area so that if some sort of pathogen has been introduced, the white blood cells can fight off that pathogen and fight off the infection, keep the body healthy. We also get mast cells releasing histamine for that inflammation, and inflammation to a point is actually a good thing. Inflammation can help remove foreign material, can help remove damaged parts, cells, and will prevent the invading microorganisms. All because with inflammation, we get the leukocytes, we get the histamines, we get the red blood cells. As that's happening and as that is controlling things, then we get the development of the new cells that will move into place and continue the healing process to ensure that the body reforms whatever was broken and replaces the cells that were damaged. And if we don't provide appropriate care, the body is not going to have the time or the resources to be able to do these things. Once that happens, and as that's continuing, once we start to see those new cells move into the place, the new blood vessels will form so that clot can be removed and the walls of the blood vessels will be repaired. And then the collagen builds up to provide stability to the wounded area as everything reforms and the skin moves back together. Again, that's not saying that there won't be a scar or there might not be some sort of physical disability, but in the long run, we should see, as long as our body has reacted appropriately, we should see our wounded area return to almost near original strength. So let's specifically look at closed injuries. Remember, closed injuries occur when there is not a break in the skin. So in this case, we're looking at wounds that maybe there's history of a blunt trauma. They fell and hit their leg, or they were hit by something. We're looking at a patient who's going to complain of pain at the site of injury, a patient who may exhibit swelling, discoloration, and even potentially deformity at the area of injury. Again, though, the skin has not broken. When we have closed injuries, we see an increased likelihood of contusions forming. Remember, contusion or bruising is bleeding beneath the skin. So it is internal bleeding, but because there's not a break in the skin, it won't escape. And it will therefore collect under the skin and create that bruise. The hematoma occurs when blood collects within damaged tissue or a body cavity. And hematoma tends to be more of a bump. It's much more of a buildup, so it's much more of a raised area where the bruise is just discoloration of the skin. Both are going to be painful, and both are going to be discolored. But where the contusion is bleeding beneath the skin, it kind of spreads out. The hematoma collects within a specific area and tends to create just a single space of issue. Another type of closed injury is a crushing injury. A crushing injury occurs when there is significant force to a body area. So I have something fall on my foot, or I am in a car accident and the dashboard is deformed down onto my legs. The extent of the damage is going to be varied based on the amount of time that object is putting pressure against me, and it's also going to be determined by the amount of pressure. So if I'm hit by a car or run over by a car, obviously that's going to be more force than if I drop a TV on my foot or if I drop a book on my toe. When we have an area of the body trapped for 4 hours or greater, arterial blood flow is going to be compromised, and we're going to start to see what we call crush injuries. So when the arterial blood flow is compromised, the tissue is not getting oxygen, and we're also not then able to remove the waste that will build up. You have to treat this appropriately, working with ALS providers to ensure a fluid replacement, working with the fire department to ensure appropriate extrication, that type of stuff. And when we have crush injuries, we increase that risk of compartment syndrome. And compartment syndrome is when there is swelling or edema in the area of the injured extremity or injured body part that can't be released. And so the swelling builds up. It can compromise circulation. It can crush and cause pressure against wounds that already exist. Or even create wounds and damage that didn't occur from the original crush injury. We see significant likelihood that there is an increased chance of tissue death if this is not treated in a timely manner. And treatment may include opening the wound up to allow blood to flow out, surgery, etc. The more we see patients who have these closed injuries that potentially were the result of a significant amount of force, the greater we have to continue to think that this could be a crush injury that leads to compartment syndrome. So those are closed. Now let's look at open injuries. Again, as a reminder, open soft tissue injuries are the result of an damage trauma that leads to a break in the skin. We need to recognize that when we have an open wound, it is likely that that break in the skin has caused a contaminant to enter the body, which increases chances of infection, etc. We have multiple types of open injuries that we are going to look at. The first being abrasions. Abrasions occur when friction rubs apart and friction with a hard surface, so road rash, someone who is ejected or falls off their bike and skids down the road a little. That's the friction that we see. That will cause an abrasion. An abrasion is superficial, so it's only causing damage to the epidermis, and it is painful because we're exposing the nerves in the dermal layer. It can ooze because of the capillaries. So while we're not likely to see significant blood loss from an abrasion, we may see some oozing from the capillaries. We're going to have, again, some pain because of exposed nerves. And we may also need to be concerned still about the chance of infection because this still is an opening in the skin. Next is a laceration, which is a jagged cut. Lacerations have, as you can see in the picture there, they have edges that maybe are a bit more rougher because it is tearing the tissue. Lacerations that are clean are really referred to as incisions. Lacerations can go deep. They're going to end up into the second layer of the skin, so you might see even more excessive bleeding. You might see arterial or venous bleeding depending on vessels that are damaged. You might see a patient who has a lot of pain or no pain depending on whether the nerves were damaged or exposed. So you've got to be concerned with lacerations that your patient is going to need bleeding control assistance, and that there may be, again, more damage even further into the wound than you can visualize during your assessments. Third, we have an avulsion. An avulsion is basically a flap of injured skin. So it can also be completely detached, and it goes deep into the epidermis and the dermis, creating a flap again, or it might have been completely pulled off. There is often significant bleeding, again, because it is going so deep into the wound or into the skin, you expect the veins and the arteries that feed the skin to be damaged as well. An amputation occurs when a body part is completely removed. So it can be a finger, the tip of the finger, a toe, the arm, a hand, etc. It is not always going to have massive bleeding. If an extremity is amputated with quick movement and clean wounds, so it's a clean laceration, then you may not see significant bleeding. But regardless, it is a soft tissue injury, and our goal is, again, to control the bleed, which likely is going to require a tourniquet. Direct pressure, pressure bandage, tourniquet. So with these soft tissue injuries, if you come across a patient who has significant bleeding or even insignificant bleeding, but uncontrolled bleeding, you are going to follow the steps that we went over in the previous chapter. PPE is going to be important, making sure that you are wearing your gloves and then providing the appropriate care based on the injury. A penetrating wound or a puncture occurs when you have not only a break in the skin, but a piercing object. So your patient was running with scissors and tripped and fell. Your patient was using a knife and slipped. Each of these is going to be considered an impaled object or a penetrating wound. Our concern with penetrating wounds is the damage that might have occurred further into the wound that we cannot see. When you have a stabbing or a shooting, you've got a patient who likely has multiple penetrations, multiple penetrating injuries. So your goal in these is to make sure that you treat all of the wounds. If you are counting stab wounds, so how many times were they stabbed, especially if you are counting gunshots, if you are counting entrance wounds, you need to consider whether or not there might be an exit wound. So if my patient was shot and I'm counting entrance wounds, I should also turn them over and count exit wounds, recognizing that entrance is going to be smaller than exit wounds. It's going to be important to know whether you've treated them all, whether all of the bullets came out of the body during the shooting, or if there might still be some that could cause damage as you treat the patient and transport them. As we've talked about, if your patient has been shot, the type of gun and the size of the bullet can play a role in the expectation of further damage and further injuries. So you've got to figure it out and recognize that, is this self-inflicted or is this potentially someone else causing harm to the patient? Your penetrating traumas, your shootings, these patients are likely going to become cases that end up in court. Another wound that we might see as a result of creating soft tissue injuries are the blast injuries. And we talked about there's kind of 4 stages of blast injuries, 4 times that you might get injured. So the primary blast injury can cause soft tissue damage. The secondary blast injuries from the debris can obviously cause soft tissue damage. And of course, the tertiary injuries from being propelled into an object can likely cause soft tissue injuries as well. It is, as with the internal bleeding versus external bleeding, when we are talking about a closed or internal wound, it is obviously going to be harder to assess those injuries than it is to assess a patient who has open wounds. So we need to kind of follow our process. We need to make note of the things we find, and we need to not assume anything unless our patient assessment has shown it to us. So we've got to again consider the bruising, swelling, and deformity. Because we don't have x-ray vision, because we don't have MRIs in the field, we have to make assumptions and have high levels of suspicion of injuries. So if my patient has a painful, swollen, deformed extremity, I have a high suspicion that they have a fracture. But I can't guarantee that's what it is until the hospital conducts x-rays. How do we find them though? Not just, knowing the mechanism of injury and maintaining high levels of suspicion. What are our steps to finding soft tissue injuries? Well, the first one's easy. It's scene safe. Am I wearing the appropriate BSI? Scene safety. From the nature of illness, from the dispatch information, you might have an idea of whether or not the scene is going to have hazards you need to be aware of. So is this a car accident that happened on the interstate? In which case you've got to be worried about all of the other traffic. Or is this a patient who fell down a flight of stairs? And you see that's going to potentially create a decreased risk of a threat to you. Making sure that, was this a fight and now there are a lot of bystanders that you have to be concerned with? Do you need additional resources? Would some ALS backup help you? Or do you need law enforcement on scene for traffic control or crowd control? Those questions aren't any different than the ones you've asked yourself because of your medical calls or because of your difficulty breathing, those types of things. Both with the dispatch and as you arrive on scene, look for the mechanism of injury. Look for the different indicators of what injuries you should expect or prepare to treat with your patient. We're going to identify our life threats. When I get up to the patient, do I see significant bleeding that is considered a life threat that maybe needs to be treated even before I move on to my airway and breathing assessment? Let's do a primary, a general impression. How does my patient look? What condition are they in? What does my gut tell me I may be dealing with? Again, though, please, please, please do not get tunnel vision. Just because you've had this type of accident before or seen this type of traumatic injury doesn't mean it's going to be the same this time as it was last time. What that means is you need to think to yourself, okay, well, the last time I had one of these, I needed to be prepared for X. So I'm going to be prepared for X as well as Y and Z, so that you are ready for whatever this patient may throw at you differently. I'm going to assess after that my airway and my breathing. So is the airway open? If it is, fantastic. If it's not, let's appropriately open the airway. Since this is trauma, I'm probably going to consider using the jaw thrust instead of the head tilt chin lift. I'm going to insert an oral airway if necessary. I'm going to apply 15 liters non-rebreather if I think it will help. I'm going to consider whether or not my patient needs to be suctioned. If my patient has traumatic injuries, I'm going to consider the need for spinal immobilization and C-spine control. And at the breathing, as part of this, I may expose the chest now and listen to lung sounds and just ensure that there's no major physical deformities or traumatic injury that might be hindering the respiratory effort. I'm going to check circulation. If when I checked for some life threats, I'd noticed an open wound, I might have already had to control bleeding. But if there was no major bleeds, no life threats at that point, now might be the time that I'm going to find it and treat it. So I'm doing my head to toe. So from the top of the head to the base of the toes, major bleed check, noting any non-significant bleeds to treat later. I'm going to check cap refill, making sure it's less than 2 seconds. I'm going to check pulses, making sure that not only are they there, that they are strong and regular. I'm going to make a transport decision. Remember in the chapter on trauma overview, we talked about some of the mechanisms of injury that should be considered high priority. Does your patient fall into one of those categories? If so, let's get them packaged and get them into the ambulance. Do they have an altered level of consciousness that you found during your initial check? Or are they in severe pain or experiencing severe difficulty breathing? What are their vital signs? Have you taken those? Are they having difficulty breathing or uncontrolled bleeding? All of those should be considered high priority patients. Now I'm going to get into the sample and the OPQRST. If my patient is conscious, if my patient is alert, if my patient is complaining of a specific injury or specific area of pain, then I am going to focus in on that area and conduct a focused physical exam. However, if my patient is altered or has experienced a significant mechanism of injury, I am going to do a head-to-toe rapid assessment using DCAT BTLS to find those injuries. Remember, deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. Typical signs that I would expect to find when my patient has open injuries and open soft tissue injuries: bleeding, breaks in the skin. So as I do my head to toe, whether it was during the circulation check or during my rapid physical exam, I might find that my patient has a cut or laceration or even an amputation. Disfigurement or loss of a body part, so obviously amputation, and uncontrolled bleeding. After I've evaluated those ABCs, now I'm getting into that DCAP BTLS. If my patient complains of only one pain or one area of injury, then that's what I focus on. And I'm going to still do DCAP BTLS to that area, but I'm not necessarily going to do a full body scan. But if my patient is altered or has a significant mechanism of injury, that's when I'm going to do the head to toe. When I do my physical assessment head to toe, I also need to consider some of the extras. Have I listened to lung sounds yet? If not, when you're assessing the chest for DCAP BTLS and feeling those ribs, checking for breaks, now's a good time to expose the chest and listen to breath sounds. Is my respiratory effort good, or is it taking me a lot of accessory muscles? Do I notice that there's not equal rise and fall of the chest? All of these may point to signs of some internal injuries I have not seen yet. I'm going to make sure that when I get down to the arms and the legs that I am checking for pulse, movement, and sensation. Remember, push, pull, tickle. Can you squeeze? Which hand am I touching? Wiggle your fingers. Can you push down? Which foot am I touching? Wiggle your toes. When you're at the pelvis, remember we're going to push in on both sides and then push down. And with our abdomen, we're going to palpate all 4 quadrants. Guys, this is going to help. That patient may have severe pain in one area of the body that has taken all of their attention, but in reality, their biggest and most significant issue might be something that they're not even complaining of. And so by doing a head-to-toe assessment, you're going to be able to find it and treat it. I'm going to get vital signs. So if it's me and my partner and we're doing this in the back of the truck because the patient was a load and go, then as I'm doing DCAP BTLS head to toe, I'm going to have them get a set of vital signs. Remember, the vital signs can tell us how the body is coping with this traumatic injury. Are they maintaining quality pulse? Are they showing drop in blood pressure? All of those being, things that can kind of tell you how they're handling it and whether or not they're going to start to decompensate while you're transporting them. If my patient has that high heart rate, they have high respiratory rate, they have low blood pressure, they're experiencing pale, cool, and clammy skin, I've got a patient who is likely in hypovolemic shock. They should already be on oxygen. You should have them in Trendelenburg, covering them to prevent heat loss and getting them to additional assistance as quickly as possible. Once we have gone through our primary and our secondary, gotten our vital signs and taken a quality history, now it's time to reassess our patient. Remember, you may not get to any of this if your patient's injuries are severe enough. You may never have been able to have left airway, breathing, and circulation. You may only get a single set of vital signs. And that's okay as long as your patient's condition warrants that. But if you do get to do those things, remember, reassessment includes the vital signs, the primary assessment, your interventions, and making sure that your patient is doing better or at least the same as you transport them to the hospital. We recheck our high priority patients every 5 minutes. We recheck our low priority patients every 15. Doesn't matter if they're trauma, doesn't matter if they're medical, every 5 and every 15. We're of course going to review our interventions. If they're on oxygen, is it still enough? Or do I need to now bag my patient? Is their respiratory effort still quality? Are they still able to maintain an open airway, or do I need to put in an airway adjunct? Do they need to be suctioned? Have I treated all of the wounds appropriately? So have I put bandages everywhere they need to go? Have I considered that bleeds aren't controlled and done what needs to be done? Now's the time to go back through that so that when you roll up to the hospital, you're not showing up with a patient who still needs care and maybe isn't doing so well anymore. You know, we're going to treat the small wounds too. So while during our circulation check, we're going to stop and treat the major wounds, if we've gotten to our secondary assessment and if we have found more insignificant minor bleeds, minor wounds, now's the time to treat those. Just because they are not as bad as others doesn't mean you shouldn't eventually get a Band-Aid on them or treat them so that all wounds have been cleaned, so maybe flushed with sterile saline, and then bandaged appropriately. Communication and documentation, just as important in your soft tissue injuries. What injuries did you find and how did you treat them? How did they respond to the treatment? So if I notify the hospital that I'm en route and I don't tell them that my patient has an amputation, imagine the surprise on the nurse's face when you show up with a patient who's missing a limb. Or if you show up still trying to control a bleed that you didn't notify the hospital about. I can promise you, if you don't communicate what your patient has, what you've done and how they've reacted, it's probably not going to be received well by the hospital staff when you drop your patient off.